Very good morning to all of you. A warm welcome to the Ceylon College of Physicians Specialty Update on Gastroenterology, organized by the Ceylon College of Physicians in collaboration with the Sri Lanka Society of Gastroenterology. Today's academic program brings together an esteemed panel of experts who will be sharing valuable insights into chronic diarrhea and chronic pancreatitis, two important and challenging areas in our clinical practice. To formally commence today's proceedings, I now invite Vidya Jyoti Professor Prasad Katulanda, President of the Ceylon College of Physicians, to deliver the welcome address.
Good morning, ladies and gentlemen. It's my great pleasure to welcome all of you for the last specialty update of this year by the Ceylon College of Physicians, which we are conducting in collaboration with the Society of Gastroenterology of Sri Lanka. And here I especially welcome colleagues from the Society of Gastroenterology. There are the seniors, middle tier and the juniors, particularly my friends Sanjeeva, Nilesh and Madhunil and the rest of the team. So I see that we have come up with a very good program today, particularly useful for both patient management as well as particularly for the trainees in terms of their exams and training, also very useful. Quite common topic, chronic diarrhea, but going into the depths like the Crohn's disease, again very important conditions to recognize and manage, as well as niche areas in gastroenterology which the internists also should know, chronic pancreatitis. So I am thankful to the team from the Society of Gastroenterology and our team from CCP for coming up with this very good program today. And also I hope this program would be very academically enriching as well as interesting, and also acknowledging our sponsors who have sponsored this event, Abbott and George Stewart. I would wish that you all have a very good program in the afternoon. Thank you very much.
Thank you very much, Professor. We now move on to the first symposium of the day on chronic diarrhea. To moderate the discussion, we have two gastroenterologists, Professor M.A. Niriyala, Professor in Gastroenterology, Consultant Gastroenterologist, Faculty of Medicine, Ragama, and Dr. Sanjeeva Aryasinghe, Consultant Gastroenterologist, National Hospital of Sri Lanka. Over to you, sir.
Thank you very much. So this is the symposium on chronic diarrhea, and we have three very interesting talks that will follow. And for the first talk, I'd like to invite Dr. Hasita Vijayawantha, who is consultant gastroenterologist from the National Hospital of Kandy, to give a brief outline on the evaluation of a patient with chronic diarrhea. Over to you, Hasita.
Thank you. Good morning. First of all, I would like to thank Ceylon College of Physicians for giving the SLSG the opportunity to conduct this specialty update. And special thanks to Dr. Sandeepana Gamage and Dr. Dhanushi Abenayaka for organizing this event. I will talk to you about evaluation of a patient with chronic diarrhea, clinically oriented brief update over next 15 minutes. So now this is one of the one of the commonest complaints that you would hear from patients during your consultations. So when patient says that he or she has diarrhea, what going through the patient's mind would be loose consistency, increased frequency or urgency of bowel movements, and sometimes it may be incontinence. However, as doctors, you might think more objectively and in a scientific sense that the diarrhea is passage of more than 3 liquid stools per day, and stool amount of more than 200 grams or 200 milliliters per day, or stool consistency of type 5 to 7 on Bristol stool scale. However, now in our setting, where we are mostly on non-Western high fiber diet, the stool amount of 200 grams is not considered in defining diarrhea. So what is pseudodiarrhea? So pseudodiarrhea is frequent defecation with normal stool consistency, and it's not, it doesn't fit into that definition of classical loose stools. So then this is the workable, there are various definitions, and this is one of the clinically useful definitions of chronic diarrhea. Persistent alteration of stool consistency from the norm with loose stools, type 5 to 7 on Bristol stool chart, and increased stool frequency of greater than 3 stools per day for at least 4 weeks duration. So as you can see, the stool weight has been omitted because the people like us who are on a high fiber diet, the weight can be, weight can be more than 200 grams a day, even without increasing stool frequency. So diarrhea is a symptom and not a sign, a symptom and not a disease. So the underlying cause can be it can be caused by numerous conditions. So even new onset diarrhea of less than 4 weeks duration may reflect serious organic disease. It would depend on the particular clinical scenario. So then the diagnostic approach may vary depending on likelihood of a specific diagnosis. That means if a patient who is more than 60 years of age presents to you with a history of 1 week diarrhea with passage of blood and a history of weight loss, you might consider it as serious, even though it does not fulfill into the definition of chronic diarrhea. Therefore, your diagnostic approach would depend on the likelihood of a specific diagnosis and availability of treatment, severity of symptoms, patient preference, comorbidities, and most of the time, more than 90% of the time, you might be able to achieve a specific diagnosis. So just like everything else in medicine, history is one of the most important part. When it comes to chronic diarrhea, it is the most important step. So you have to, history, it is onset, pattern, duration, especially duration, when especially if it is less than 3 months, it is more likely that you would find an organic cause. Whereas the diarrhea which goes on for ages, like without any further alarming symptoms, it's more likely to be functional diarrhea. And comorbidities and history of travel, food and water, and family history, and stool characteristics, whether it is watery, bloody or fatty, and the volume of the stools, and associated symptoms like tenesmus, urgency, incontinence, abdominal pain, weight loss, and loss of appetite, and aggravating factors, whether it is improving with fasting. I mean, as you know, that osmotic diarrheas improve with fasting, and mitigating factors, and previous history of diarrhea and previous history of evaluation, the drug history, radiation history, and Clostridium difficile is a possibility among inpatients who have been on broad spectrum antibiotics, past history of surgery like cholecystectomy, extensive bowel surgeries, bypass and ileal resection, and associated systemic diseases, and laxative, factitious diarrhea, laxative abuse. So in evaluating chronic diarrhea, this is one of the most important steps. Recognizing red flags early, as I explained to you earlier, even though the diarrhea may be less than 4 weeks duration, and it may not be, fitting to the classic definition of chronic diarrhea, recognizing and identifying red flags is very important. And bleeding per rectum and associated anemia, unintentional weight loss, diarrhea disturbing sleep or nocturnal diarrhea, raised inflammatory markers, associated fever, onset after the age of 60, electrolyte imbalances, and high volume diarrhea. That means more than stool weight and stool frequency. So then physical examination, as you would have experienced, most of the time examination is negative in our diarrhea patients. However, these are the important signs that you would focus on, and this is not a comprehensive complete list. However, you must focus fluid balance, nutrition, BMI, and scleritis, episcleritis. Those can be features of inflammatory bowel disease, and mouth features of nutritional deficiency. Arthritis can be associated with inflammatory bowel disease. Wheezing can be associated with carcinoid syndromes, heart murmurs, skin flushing rashes and dermatographism. Thyroid is a well-known cause of diarrhea. And an abdominal examination is equally important. And I would like to take your focus your attention on this examination, anorectal examination. So, overflow incontinence is one of the commonest mimics of diarrhea, especially in elderly and people with learning difficulties. So, do a PR examination. Sphincter tone would give you a clue whether this is incontinence. And fistulae and abscesses, it may give you clues to the diagnosis of Crohn's disease. And overflow of incontinence, if the rectum full of feces, that would give you a clue to overflow incontinence. These are, I mean, for the medical registrars who are here, these are familiar picture tests: episcleritis and erythema nodosum, and this is a patient with hypothyroidism, glossitis and angular stomatitis, dermatitis herpetiformis, and pyoderma gangrenosum, and this is a large tongue of amyloidosis. And so this is the diagnostic algorithm proposed by European Association of Neurogastroenterology and Motility to investigate chronic diarrhea. When a patient presents with chronic diarrhea, the symptom-based approach that we have discussed earlier, and you have to inquire whether there are any alarming features. If there are no alarming features, only limited screening testing is indicated, like full blood count, CRP, fecal calprotectin, and celiac serology. It may not be relevant in our sitting. I will discuss it later on. And if there aren't any abnormality, you can start treatment as for functional diarrhea or IBS. However, even after starting treatment as for functional diarrhea or IBS, you have to continuously monitor. If the patient has severe persistent symptoms, then the further investigations are needed. When there are alarming features, you have to, the further investigations would be patient specific, depending on individual case as indicated. So diarrhea can be broadly subdivided into fatty or steatoric diarrhea, watery diarrhea, or inflammatory or bloody diarrhea. And watery diarrhea can be further subdivided in depending on the stool osmotic gap, secretory diarrhea and osmotic diarrhea. Osmotic diarrhea improves on fasting, whereas secretory diarrhea would not. So these are the common causes, and I'm not going to go into detail. And then these are the causes of diarrhea according to pathophysiology: secretory diarrhea, osmotic diarrhea, malabsorptive or steatoril diarrhea, inflammatory causes, dysmotile causes, other causes like GI malignancies, radiation, chronic infectious and factitious diarrhea, and fecal impaction and overflow, as I discussed earlier. Elderly patients, patients with learning difficulties, neurological and spinal diseases, those are diarrhea mimics. So chronic diarrhea can be broadly subdivided into functional and organic. Functional diarrhea is diarrhea predominant IBS and functional diarrhea, and I will discuss the differences between the two later on, and these are the organic causes. So symptom analysis and examination will help to identify patients who need further evaluation, and patients who fulfill the criteria for IBS or functional diarrhea can be started on a trial of treatment without exhausting process of investigations. So irritable bowel syndrome, the criteria that we use to diagnose irritable bowel syndrome is ROM4 criteria: recurrent abdominal pain on average at least 1 day per week in the last 3 months, associated with 2 or more of the following criteria: related to defecation, associated with a change in frequency of stools, associated with a change in the form of stools. Abdominal bloating and distension is typically present. Symptom onset should be at least 6 months before the diagnosis, and symptoms should be present during the last 3 months. So the IBS diarrhea means when the patient has more than 25% of loose stools and less than 25% of the time hard stools. The difference of functional diarrhea is it does not fulfill all the criteria that is needed for IBS. I mean, mainly abdominal pain and bloating are not characteristic features. The rest of it more or less the same. And then, however, this symptom-based criteria are only 75% specific. That's why I told you earlier, when you have started a patient on treatment as for IBS, you have to keep monitoring them. Always watch out for red flags to detect any significant etiologies and pathology directing towards functional organic cause. After initial evaluation, if it is suggestive of colorectal neoplasm, colonoscopy, and if the severe, persistent or atypical symptoms and signs or presence of alarming symptoms or anything to suggest inflammatory bowel disease, please seek specialized opinion. And the secondary assessment, colonoileoscopy with biopsy series, cross-sectional imaging, CT and MRI, upper GI endoscopy and duodenal biopsies to diagnose celiac and tropical sprue, and celiac serology. And I have seen people requesting endomysial and tissue transglutaminase antibody very frequently in patients like this. However, these tests have reduced sensitivity and specificity in low prevalence setting, whereas Sri Lanka is a low prevalence setting for celiac disease. Remember that these tests are not specific or sensitive to diagnose celiac disease. So if IgA deficiency is present, IgG endomysial antibody or TTG should be used. And video capsule endoscopy is useful when endoscopy and cross-sectional imaging are negative. And enteroscopy has a limited value. However, it is useful to detect pathologies already detected by cross-sectional imaging and video capsule endoscopy. And endoscopic ultrasonography is very useful in diagnosing early chronic pancreatitis. And MRI can be very useful, especially magnetic resonance cholangiopancreatography with secretine is useful detecting early pancreatitis when the pancreas is normal otherwise, with only asymptomatic elevation of amylase. And bile acid diarrhea is one of the commonest causes which we underdiagnose, and 1/3 of patients labeled as IBS have bile acid malabsorption. 75 selenium homocholic acid taurine test is the diagnostic test. When it is not available, it is justifiable to start the patients on cholestyramine trial. Small intestinal bacterial overgrowth, you can, breath tests are not sensitive. It is justifiable to try a trial of cyclical antibiotics. Fat malabsorption and lactose intolerance are the other causes. These are rare causes. Rapid intestinal transit, post-vagotomy and hypothyroidism, diabetic autonomic neuropathy, and fecal incontinence. Fecal incontinence, rational investigation protocol should be followed. Anorectal manometry and endoanal ultrasonography are used only when surgical interventions are planned. The other rare causes are VIPoma, gastrinoma, and carcinoid tumors. So finally, the take-home messages. Diarrhea is a symptom and not a disease. Detailed history is the most important step in evaluation of chronic diarrhea. Stool frequency, type, amount, nature, and duration give valuable clues to the underlying etiology. IBS and functional diarrhea should be positively diagnosed based on clinical criteria and not by exclusion through exhaustive investigations. Symptom-based criteria for IBS has only moderate specificity, so clinical judgment and continuous follow-up is essential. Most patients require only limited screening tests after a careful initial assessment. Patients with red flags, persistent symptoms, and those refractory to initial treatment warrant further investigations. And finally, we have our sessions in Kandy from October 30th to November 1st, and all of you are most welcome, and see you in Kandy. Thank you.
Thank you, Hasita, for that fantastic overview of chronic diarrhea evaluation. We shall keep the questions to the end of the symposium and move on to the next lecture, which will be on the management of Crohn's disease, which will be delivered by Dr. Hiruni Jayasena. So may I invite Dr. Hiruni to come over to the podium. Dr. Hiruni is consultant gastroenterologist and senior lecturer in medicine at the Sir John Kotalawala Defence University. Over to you, Hiruni.
Thank you, sir. Thank you to the Ceylon College of Physicians as well as the organizing committee for inviting me to give this talk. Management of Crohn's disease is quite a large topic, and I will do my best to complete it in 15 minutes. This is a brief overview of what you'd expect. So to begin with, Crohn's disease was first described in 1932 by Dr. Beryl Crohn as well as his colleagues. And at that time, in fact, most small intestinal disease was thought to be intestinal tuberculosis. And as my previous speaker mentioned, Crohn's disease is a multisystemic disease. It can involve any part from mouth to anus in the GI tract, and there are extra intestinal manifestations which can make it quite challenging. But diagnostic capabilities have also improved from barium follow-through to now we are having capsule endoscopy as well as ultrasound small bowel, which will help revolutionize diagnosis as well as management of Crohn's disease. So the main aim of treatment is to induce and maintain clinical remission, to achieve mucosal healing and prevent any complications, and also promote a healthy lifestyle. The management decisions are usually based upon disease location, severity of disease, presence of disease-associated complications, as well as factors that are affecting future prognosis. And these factors are that of the following, which is less than 30 years of age at initial diagnosis, extensive anatomical involvement, perianal disease, as well as presence of deep ulceration, and prior surgical resection, stricturing or penetrating pattern. So I'd like us to meet our patient. It's not one of these famous people who have Crohn's disease. Our patient is actually a 29-year-old manual laborer with weight loss and anemia and watery diarrhea of more than 1 year. He's hemodynamically stable, cachectic, but with a BMI of 17.6. He's pale, and there are other features of nutritional deficiencies, as well as having right iliac fossa tenderness. On investigations, he's got ongoing inflammation. As you can see, CRP is 140, HB of 9.2 with a platelet of 512. Ultrasound abdomen showed presence of ileal thickening, and a colonoscopy showed presence of longitudinal deep ulceration at the terminal ileum. I'm very sorry, my slides are going really fast. There's also presence of ascending colon with normal mucosa in between. Biopsy obviously showing architectural distortion, shortening villi, and cryptitis with non-caseating granuloma, and obviously nothing else but Crohn's disease can cause all of this. So what is the initial treatment for induction? This is what we have in our arsenal, and I'm sure most of you all have come across these medications. And essentially, corticosteroids are very useful in inducing clinical remission and as a bridge to symptom control, but they're not good for achieving mucosal healing. And you must always remember they can promote the development of perforating complications and decrease the effectiveness of steroid-sparing agents as well. We have two types that we could use, the ileal release as well as the systemic corticosteroids. The ileal release, which is budesonide, is used in mild to moderate disease that's confined to terminal ileum and the right colon. It has high topical activity with low systemic bioavailability with extensive first-pass metabolism. But we don't seem to have it in Sri Lanka, not yet. Hopefully we'll get it in the future. We do have systemic corticosteroids, which we are using for mild to moderate and severe disease. We can start them on a reducing course of prednisolone, but generally beware of the side effects, as well as remember that up to 15% of most patients who are on steroids will become steroid dependent at some point. 5-ASAs, they are effective in ulcerative colitis, but not so in Crohn's disease. And that has been shown time and time again with lots of studies that have looked at the oral mesalamine as well as the topical mesalamine action in Crohn's disease. But the American College does recommend maybe using sulfasalazine in mild colonic and ileocolonic Crohn's disease, but even then there's not much in the way of mucosal healing. Immunomodulators should not be for induction because they have a very slow onset of action, but they're very good maintenance therapies. So what about biologics? Earlier the better. That is the recommendation that comes from 3 reputable organizations, that we should induce and maintain patients on biologics early, and also to introduce them right at the start of the disease, because that will prevent further complications from arising as they progress through life. So we do have a lot of biologics that are available. In Sri Lanka, of course, we have anti-TNF as well as interleukin blockers. On cost and efficacy basis, it's actually the anti-TNFs that are first line. And then we do have the small molecules, which are JAK inhibitors, upadacitinib, that has the best evidence for use in Crohn's disease. So a little bit more about the anti-TNFs and the anti-interleukin, which is infliximab and adalimumab, which are your anti-TNFs. Infliximab is given as an IV infusion, and after induction, you can give it every 8 weekly. Adalimumab is given as a subcut, and after induction, you can give them every 2 weekly at 40 milligram. Ustekinumab is given as an IV induction to begin with, followed by subcut 8 weekly injection. They are all, at the moment, deemed as safe in pregnancy, given the data that's come out. However, you have to be aware of reactivation of TB, hepatitis B, C, if not been diagnosed. There's a link to malignancy, especially lymphomas, and also have to be careful when giving live vaccines. So as I mentioned earlier, early anti-TNF therapy has been shown time and time again to be very useful in reducing the associated complications and giving higher clinical remission rates and mucosal healing, as shown in this trial. It has done head-to-head studies of biologics and found to be the same. And the profile study, which was a landmark study that was done last year, showed that top-down therapy should be considered as the standard of care for patients with newly diagnosed active CD, because at 1 year, the accelerated escalating therapy, which is what we usually do, is not as efficient when you compare it with the top-down therapy, which is when you start with infliximab and azathioprine combination right at the start of the diagnosis of Crohn's. How about surgery? We don't have to be afraid of the surgeons, and in fact, you can call them early for those patients who have limited disease. So if they have ileal disease or ileocecal disease, having an ileocecal resection might actually be beneficial for the patient rather than putting them on to 8 weekly anti-TNF therapy. So back to our patient. Patient has been started on 40 milligram once a day course of prednisolone. He is clinically improving, but of course, we need to think about maintenance therapy. And with regards to maintenance therapy, this is what we have, as you knew from before. But just a brief word to say that there's no place for maintenance therapy when it comes to corticosteroids and 5-ASA in Crohn's disease. Multiple studies have looked into this, and it doesn't show any mucosal healing. With regards to immunomodulators, steroid-sparing agents, which are namely azathioprine, 6-mercaptopurine, methotrexate. I know this slide is quite busy, but it's just a brief overview of what they are known for. So azathioprine is something that is a prodrug, and its active metabolite is 6-MP. And in fact, when given in combination with azathioprine, has been found to be very useful because it reduces the immunogenicity of the anti-TNF therapy as well, and has been useful in both pregnancy and post-surgery Crohn's disease. Additionally, methotrexate, which is like our third-line immunomodulator, can be given as a subcut or an IM, but the oral option has not been found to be effective. Unless patient has a normal small bowel, the absorption is tend to be quite low. So therefore, do not recommend oral use of methotrexate. Additionally, there are a lot more side effects related to methotrexate, and when used in combination, they found that having infliximab monotherapy and combination therapy, there was no difference. With regards to pregnancy, you know that there is already teratogenicity attached to methotrexate. How about biologics? So as I mentioned earlier, 3 main bodies have recommended the use of anti-TNF therapy and maintenance and in remission in moderate to severe Crohn's disease. and it can be given in combination with azathioprine, and as well as adalimumab and azathioprine can also be given in combination to achieve endoscopic mucosal healing and reduce relapses. But please remember to always do the pre-treatment screening with hepatitis B, hep C, retroviral, chest X-ray, and manto. And if manto is positive, we should do a IGRA. If, let's say, patients do not respond to infliximab therapy or combination therapy, then there's possibility of a primary loss of response, which means that we need to switch the class of drug. It may not be the anti-TNF pathway that we need to attack the inflammation. It might be a separate inflammatory pathway that is driving the inflammation. So ustekinumab is the next option. So back to our patient. He was started on azathioprine 50 milligram once a day with a tapering course. He felt well, but 2 weeks afterwards, he was complaining of nausea, vomiting, stomach cramp, and ongoing symptoms. So, of course, we need to think about the other possible causes, but in this instance, given the recent starting of azathioprine intolerance is what we need to think of. And this is because there could be what we call thiopurine methyltransferase levels might be low, and that puts the patient at developing high risk of drug toxicity. And therefore, in the UK, for instance, 1 in 300 people have TPMT deficiency. We don't know our numbers for Sri Lanka as yet, but generally, if they have low TPMT levels, there's a risk of high drug toxicity. But given that this patient has high risk factors of age being less than 30 with deep ulceration and disease extent, he should go for a switch to ideally biologics. As I mentioned with the previous slides, that will be the best option for him. So back to our patient, he was switched on to 6-MP with steroids until we finished the biological screening. The manto test was done, and it's become positive at more than 15 millimeter. And in that instance, the rest of the TB tests were completed, and they have come back negative. So the question is, do we give or not give infliximab? And in fact, it all goes down to the TNF inhibition that takes place in the granuloma formation. It has quite an important role in the granuloma being formed and containing the Mycobacterium tuberculosis. And in fact, what happens is if you inhibit the Th1 response, and the TNF alpha inhibition will cause the granuloma to be altered and therefore disseminate the Mycobacterium tuberculosis. So in that sense, if at screening you have a patient who needs infliximab, do the manto, and if it's positive, then you need to do the IGRA because it's more specific. And if the IGRA is positive, please follow the national guidelines and treat for latent TB. TNF inhibitors can be started as early as after 3 weeks in severe Crohn's disease patients, but obviously you need to be in conjunction and discussion with the respiratory team about it. But let's say you're worried about active TB, it can actually develop after starting TNF inhibitors, because it can either happen right at the start, within 3 to 6 months of starting it, or it can happen after 20 months of starting a TNF therapy. So if that does happen, please stop all immunosuppression and treat the TB and try to complete the course. In patients who do require early treatment, in a discussion with the respiratory team, if their sputum are negative, for instance, and if they're happy for it to be started, you can commence them on treatment. So back to our patient, he's off steroids, but still remaining symptomatic, so he was started on infliximab with 6-MP, and after the third infusion, he reported improvement of symptoms, and he's due to come into clinic 8 weekly for his infliximab infusion. And finally, a word on multidisciplinary team care. It's very important that we do address this in our clinics. In addition to the gastroenterology care, they require nutrition, radiology, as well as psychological assessment, because these are chronic diseases. And finally, a word on surgery. Don't be afraid to call the surgeons for limited disease, and we do require their help if they are progressing with penetrative disease as well that are not responding to medical treatment. So in summary, medical management of Crohn's disease is growing, and the main aim is to induce, maintain clinical remission and achieve mucosal healing. Management decisions are based upon location, severity, complications, and prognostic factors. And for induction, remember, you could use corticosteroids and early biologics. For maintenance, immunomodulators and biologics together is a better option. And don't be afraid of using anti-TNF in the background of TB. It's just you need to identify whether it's latent or active TB and treat accordingly, and always aim for multidisciplinary management. I will leave this, as this is a very good slide, to, for those of you who are interested in learning a bit more about IBD treatment. Thank you.
Thank you, Hiruni, for that very nice overview of Crohn's disease and running through a patient, actual patient case discussion. Now we'll come to the third talk. It's by Dr. Dhanushi Abenayaka. Dhanushi, if we can come to the podium, thanks. She is a consultant gastroenterologist at the District General Hospital of Ambilipiti, and she'll be talking to us on an overlooked complication of nutritional rehabilitation in an at-risk patient.
Thank you, sir. Good afternoon. So I'll be talking to you about an overlooked complication of the same patient. So I'll be continuing the case that Hiruni presented and discuss on the evaluation and management. And also I'll talk a little bit on nutritional therapy in IBD. So we have a patient with severe Crohn's disease with ileocolonic involvement who was started on biologics. After 2 months, he has developed dramatic improvement with Harvey-Bradshaw index of 0, with a mild improvement in the BMI as well. So the patient was happy and then continued with promising investigations with improved hemoglobin and inflammatory markers, and liver functions and renal functions were normal. So he was changed to 8 weekly doses of infliximab. Then, due to the poor socioeconomic background of the patient, he could not continue a regular clinic follow-up, and he had to default without any medication. However, he maintained minimal symptoms with on and off diarrhea. And then 6 months later, he presented to a local hospital without any medical records with severe colicky abdominal pain and vomiting for 1 week. He felt a mass at right iliac fossa after meals, especially, and gradual weight loss after the default. He had altered bowel habits without any fever. On examination, he was having clubbing, pale, cachectic, and there were some oral ulcers. BMI has again dropped to 17.2. Abdomen was distended with right iliac fossa tenderness. The bowel sounds were sluggish. So what could be the differentials? Obviously, it could be a flare or an intestinal obstruction, but also it could be appendicitis or an appendicular abscess on the background of malnutrition and immunosuppression. And investigations, hemoglobin has again dropped to 8.2 with high platelets and inflammatory markers. That picture was suggestive of macrocytic anemia with hypersegmented neutrophils. Abdominal X-ray has shown multiple fluid levels at small bowel. So he was managed as subacute small bowel obstruction. He was kept nil by mouth and given IV fluids for 10 days. So after bowel rest, he had a marked clinical improvement, and then oral intake was restarted. So within 48 hours of restarting oral feeds, he developed marked generalized weakness with mild confusion, reduced level of consciousness with generalized tonic-clonic seizure. By that time, he was transferred to a teaching hospital. He was found to be afebrile with normal fundus. There was no neck stiffness, no focal deficits, but there was proximal muscle weakness. He was tachypneic with low saturation on air, tachycardic, hypotensive, and there were fine basal crackles. There was RIF tenderness. So what could be the differentials? Could it be electrolyte imbalance? Yes. Or Wernicke-Korsakoff syndrome with the background of malnutrition and causing severe thiamine deficiency? or infections, encephalitis causing a seizure or delirium? Could it be alcohol withdrawal? So investigations, the CT brain showed normal findings, and there were multiple electrolytes, phosphate, potassium, magnesium, all were low with hyperglycemia, and ECG showing tachycardia with findings suggestive of hypokalemia. And liver functions were normal, but there was acute kidney injury with very high CPK and dark urine without any red cells microscopically. So what is the diagnosis? We have a malnourished patient with prolonged fasting who was started on feeding with hypophosphatemia, hypomagnesemia, hypokalemia, rhabdomyolysis probably with cardiac failure. So putting everything together, it's obvious that it's a refeeding syndrome. So before moving on to the management, I would like to go back to the past where it was discovered when during World War II, where starved American prisoners were released who were already malnourished. And then when they were started on oral feeding, they have developed severe diarrhea, heart failure or convulsions or coma, some leading to death without any obvious cause. So let's see what happens during fasting. First thing to happen is reduced level of glucose, and then glucagon will be surged with low insulin. So now the body goes into a catabolic state where it finds resources for energy consumption. So first glycogenolysis, and then move on to lipid with free fatty acids and ketone bodies, and then proteolysis. On the other hand, the vitamin and micronutrient intake will be low. With low electrolytes, sometimes there could be a shift of electrolytes into serum from the cells. When you start feeding, glucose will be surged, resulting in insulin rise, and then sodium retention will result. How? Directly from the insulin effect, and followed by a fluid overload. So now the cardiac muscles are already atrophied and dysfunctioning. So this fluid overload cannot be tolerated by this poorly functioning heart, so that it will end up with cardiac failure, pulmonary edema, or cardiac arrhythmias. And the increased glucose metabolism results in thiamine deficiency because of the increased consumption compared to the supplementation. So it can develop severe thiamine deficiency with Wernicke-Korsakoff syndrome. And shift of electrolytes to the cells can cause severe depletion at serum level. And increased protein synthesis using serum phosphate can result in deprivation of phosphate in red cells and also muscles, reduce muscle ATP, causing muscle injury with rhabdomyolysis, and it may complicate with acute tubular necrosis. So this hypophosphatemia is actually a hallmark in refeeding syndrome. Phosphorus is mainly intracellular, used for multiple cellular functions, and deficiency result in organ involvement like cardiac, skeletal muscles, neurological system, and hematological. And magnesium and potassium are electrolytes and also act as cofactors for some enzyme complexes, and deficiency can lead to cardiac, neuromuscular, GI involvement, or hypomagnesemia can cause refractory hypokalemia, thiamine deficiency, and also when the water follows electrolyte shift, it can cause a secondary overload causing heart failure. So how do we manage this patient? First, we have to stop or reduce oral feeding temporarily, and then correct the electrolytes. Ideally, it should be IV phosphate. Since it's not available in the country, oral Joule solution would do. And IV phosphate, potassium and magnesium. And then IV thiamine replacement for 5 to 7 days before starting feeds. And continuous ECG and electrolyte monitoring should be there. Nutritional support should be very strict. It should be introduced with gradually, slowly, at a slow rate, and then Small, frequent, low carbohydrate meals should be initiated with gradual increase and supplementation with vitamins and electrolytes. Regular electrolyte monitoring, and we should treat the underlying Crohn's disease obviously, and support from the nutrition physician is essential in this nutrition rehabilitation. So could this complication be prevented? Most likely yes, if you have assessed for risk factors in this patient, whether the patient is having a high risk factor to develop refeeding syndrome. So NICE criteria say one or more of the following: if the BMI is very low, or if there's unintentional weight loss more than 15%, little or no nutritional intake for more than 10 days, or low electrolytes are sufficient criteria for to take the patient as a high-risk patient for refeeding syndrome. So if you assess the patient as high risk, check for electrolytes, correct if they are low, and thiamine for during the first 10 days before starting feeds, and depending on the risk, if it's a moderate risk, high risk or extremely high risk, the energy supplement should be variable. 50% of energy needs in the first 48 hours in moderate risk. High risk, 10 kilocalories per kilogram per day. If it's extremely high risk, 5 kilocalories per kilogram per day. Continuous monitoring. What should we be monitoring? The fluid balance, vitals, blood glucose, electrolytes until the patient is stable. So nutritional therapy for IBD. Can nutrition therapy be a treatment for IBD? Yes, in some instances. So why do they get malnutrition in IBD? Is it only because of the inflamed small bowel that restricts absorption and digestion? Not only that, actually, these patients are having a lot of GI symptoms, sometimes because of the disease itself, sometimes because of the as a side effect of the drug, or sometimes as a complication of surgery. And they can have bacterial overgrowth. So all these contribute to malnutrition of these patients. So this is depending on the type of the IBD, we can give a certain specific diet. So in any IBD patient, we should encourage on the typical Mediterranean diet, which is a diet rich in fruits, vegetables, and monounsaturated fat, lean protein, and complex carbohydrates. And it should be low in ultra-processed food, sugar, and salt. But if there's a stricture, obviously we have to encourage on a low-fiber diet. And also, if there's inflammation, active disease, there's a place for exclusive enteral nutrition, especially in pediatric or adolescent groups. It has shown that it could be replaced with steroids and shown to give significant clinical remission or endoscopic remission. Or Crohn's disease exclusion diet with partial enteral nutrition with oral diet. If it's a before surgery, you have to rest the bowel and reduce inflammation or infection. Then there's a place for exclusive enteral nutrition or parenteral nutrition. But if there's an abscess, infection, localized infection, or fistulation, we have to rest the bowel till it healed, so that we have to keep the bowels rested with nil oral and start parenteral nutrition. And other indications for parenteral nutrition, like high output fistula, prolonged ileus, if there's a short bowel syndrome, if there's severe malnutrition that we can't correct with oral nutrition, and if they can't tolerate oral feeds, or if there's a stricture that distal to the stricture we can't access even with tube feeding, there's a place for parenteral nutrition. So refeeding syndrome is often overlooked complication. It's because of it prompts anabolic state causing hyperinsulinism and hyperconsumption of cofactors. Management is to temporarily stop feeding and correct the electrolytes and thiamine. Continuous monitoring should be there with strict nutritional support. Prevention is always better than cure, so assess the risk factors, correct the electrolytes and thiamine, slow introduction of calories, and nutrition therapy, enteral nutrition, exclusive enteral nutrition, and partial enteral nutrition are things to consider in the management. So this is a reminder of our annual academic sessions organized by Sri Lanka Society of Gastroenterology. You all are welcome. It will be in Kandy on 30th October to 1st of November. You can get yourself registered online or at the desk outside the auditorium. Thank you.
Thank you, Dhanushi. We are left with about 10 minutes of questions.
So we have at least past 2 days with a lot of protests. Have you ever come across a patient who needed the refeeding syndrome to be experienced? Sri Lanka, we have a lot of Maranthika upawasa තියෙනවනේ fast on today. So have you ever come across a patient who needs this refeeding syndrome to be activated? So they were just funny.
Not in that type of patient, sir. Sorry.
Yeah, I'd like to ask a question from Hasita. For the trainees, what is the sort of a stepwise assessment of chronic diarrhea? What key groups will you consider in stepwise to come to the diagnosis? I think you went through.
Yeah. So, well, basically, as I explained earlier, after going through the symptoms, and then you have to broadly categorize depending on the nature of the stool, whether it is blood-stained stools, watery stools, or fatty stools. And the whole assessment would proceed from there onwards. Like if it is blood-stained or inflammatory type diarrhea, then you might need an endoscopy rather sooner than later. If it is secretory diarrhea, then the secretory diarrhea means watery diarrhea. If it could be either osmotic or secretory and mainly of small intestinal origin. And then fatty diarrhea indicates it's malabsorption. It could be maldigestion or malabsorption. Maldigestion means there is nothing wrong in the lumen of the small intestine, but there is a deficiency of digestive enzymes like in chronic pancreatitis. Whereas malabsorption means there is no deficiency in the enzymes, but then the absorptive surface or the structures behind the, after the absorptive surface, like lymphangiectasis. So, can be there. So, those are the main 3 procedures, and your investigation process should focus from there. I could not go into detail because of the lack of time.
For the training, if we can say, make sure that you are dealing with true diarrhea, exclude spurious diarrhea. So there will be a clear constipation and alternating diarrhea sort of history. If it is true diarrhea, it is either functional diarrhea or organic diarrhea. So if it's functional diarrhea, we know how to exclude the red flags and how to do it. If it's organic diarrhea, it's either intestinal or extra-intestinal. So that is the basic sort of most simplest outline. Why 4 weeks in defining chronic diarrhea?
Well, I mean, I don't know the exact reason, but most of the time, there is no exact rule for, as I explained to you earlier, like it's basically symptom-based analysis, and it's 4 weeks is when you investigate the acute inflammation takes, do endoscopy and all those invasive investigations. There is about 3 to 4 weeks when needed to become acute inflammation to chronic inflammation. For example, we do endoscopy. We don't do endoscopy in acute diarrhea patients because you cannot differentiate whether it is acute infection or chronic, something like chronic IBD, if you do too early. So that is one reason. And also, this 4 weeks, I would say, like, you should not be, it is theoretical, yes, but then the investigation should focus on the likelihood of finding an organic etiology, as I explained earlier.
Yeah, I think it's mostly most of the infective diarrheas in an immunocompetent person would settle within 1 to 2 weeks. They would not go beyond 4 weeks. In an immunocompetent patient, if the diarrhea persists for more than 4 weeks, there's something wrong. It's probably non-infective. That is why there is 4 weeks. Any questions from the audience you would like? I think Hiruni will be angry with me if I don't ask a question. So can you, for the trainees, there are, you mentioned some key clinical trials in Crohn's disease, Sonic or Diamond, if we take either of the infliximab, let's say Sonic, Calm, and Profile. In 2 sentences, can you summarize those 3? Sonic, Calm, and Profile.
So combination therapy right at the start,
So Sonic combination therapy is better than either alone?
Monotherapy, yeah, yes.
Okay.
So for Sonic, it was infliximab and azathioprine, and they found that combination of them together was better than infliximab monotherapy or azathioprine monotherapy. Diamond was with adalimumab.
Yeah. Same thing?
Same thing, adalimumab and azathioprine.
So that's at 52 weeks, mucosal healing?
Yes.
Yeah. Okay.
And Profile, which was the big study.
Calm?
Calm showed that when you start them early, right at the induction of treatment, then giving both together would be beneficial than...
A little bit different. I think Calm was actually, you have to monitor these patients and treat to target. So the treat to target concept came from the Calm study, where one group was actually treated based on the symptoms, patient-reported outcomes only. The active group was actually monitored with biomarkers. So they had sort of their inflammatory markers, they had their fecal calprotectins, so more deeper monitoring. So closer monitoring and adjusting the treatment according to whether you reach the target or not was Calm study. So don't treat your patients only based on the patient's reported outcomes or symptoms. You have to use the biomarkers and you have to make them normalize, and that is to treat to target concept. Yeah. And Profile? And
Profile showed that top-down therapy compared to the traditional way of us escalating through the different types of drugs is far better at 1 year, that they had less complications and less need for surgery if you were to hit it hard right at the start of diagnosis, especially in newly diagnosed Crohn's patients.
Yeah, thanks. Sanjeev, do you have any questions for
just to comment further on Crohn's, yes, sir. After the Profile trial only, as you mentioned, they mentioned to start biologics early and ideally within the first year of diagnosing the disease. That's when the window period is to start the biologics. And most of the guidelines are now moving forward for moderate to severe Crohn's or even ulcerative colitis, that combination is better, and there are other trials which are coming out which now combine 2 biologics and proving to have more benefit, whereas there is no increased risk of the side effect profile. So those are what will happen in the future.
One interesting observation in the Profile trial was that these patients were started on combination within weeks, not months, weeks. So we should be, if we are confident in diagnosing the patient, and Hiruni nicely went through the high-risk features of a sort of a stormy disease in the future, less than 30 onset, multisegmental disease, very deep ulceration on endoscopy, rectal involvement, perianal involvement, previous surgery. Those patients, you should not be playing with just azathioprine, they should be on combination therapy. One question, in your patient who had latent TB, if you had all the biologics, which biologics are much safer than infliximab for that patient?
So safety profile-wise, vedolizumab is the number 1 biologic. In fact, in...
Why?
It's a... I think it's already answered.
Yeah, so Vido is gut specific. It acts at the gut level. So there is no playing around with anti-TNF, it's anti-integrin. So there is no reactivation of TB with Vido. And ustekinumab also same, it's anti-interleukin. There is no TB reactivation risk. And then we have a new drug, risankizumab again.
So it's a different pathway to the TB pathway.
Yeah, so anything not anti-TNF, there is no risk of TB reactivation. For Dhanushi. Okay, can refeeding syndrome patients initially have normal potassium, magnesium and phosphate?
Yes, they can, sir, because from the beginning the body tries to compensate. So even at a low level, the body tries to compensate with the serum level. So when you check with serum, it could be normal at the beginning.
Yeah, so you can't be reassured that the patient, so do your refeeding risk assessment at the beginning and don't go by the electrolytes. You nicely went through the guidelines, the high risk, the major criteria and the minor criteria, one of major or two of minor. So they can actually have normal serum levels, but their intracellular potassium, magnesium, and phosphate is depleted. That's why they go into this catastrophe. It's a state of sort of prolonged fasting that leads them to be in a catabolic state, and you feed them and they suddenly change into an anabolic state, which drives all these things and causes a multi-system sort of a syndrome. First 3 days, I would say first 3 days very important in these patients. We have a nutrition specialist also in the audience. First 3 days, these patients should be monitored twice daily with all the electrolytes, cardiac monitoring. I think if you get through the first 3 days, then the rest of the 11 days, up to about 14 days, you can monitor daily. And sometimes at an outpatient if the risk is not very high. It's very disappointing that there are no questions from the audience.
Can I ask one question? This questions for the Hiruni. Usually in Crohn's disease, we have little hesitant to hand over the patients to the surgeon. We thought this is a surgery is the last resort. But you highlight that surgery can be an initial step of management. Can you more elaborate which patients we should refer for the surgeon?
For the study, the PREDICT study actually showed it's useful in patients with limited disease. So it looked at ileocecal involvement. So in that case, ileocecal resection might actually save the patient, sort of further complications later on, and having to be on long-term, biologics, coming in for 8-weekly infusions, and when the drug's not available, they will be sort of at a loss. So doing the initial surgery and getting rid of the disease part doesn't mean that you stop following up the patient. You can also start them on a low dose of azathioprine and then monitor them for any further disease recurrence. So that's actually something that's come out recently that has a good outcome for patients.
Thank you.
So it's only ileocecal, limited disease with no perianal disease, no disease elsewhere, and not for the fibrostenotic disease. Fibrostenotic disease is quite late actually. These are early patients with inflammatory disease, which is very interesting. I think for interest of time, I think we'll have to hand over for the second symposium, and I'd like to let us thank the 3 speakers for 3 excellent lectures. Thank you.
Thank you all. To formally recognize the valuable contributions of our speakers, let me invite the chairpersons to hand out the certificates of appreciation. Professor M.N. Iriala, Professor in Gastroenterology, Consultant Gastroenterologist, Faculty of Medicine, Ragama. Dr. Sanjeev Arya Singha, Consultant Gastroenterologist, National Hospital of Sri Lanka. And to our speakers, Dr. Hasita Vijayavantha, Consultant Gastroenterologist, District General Hospital, Matale. Dr. Hiruni Jayasena, Consultant Gastroenterologist and Senior Lecturer in Medicine, Faculty of Medicine, General Sir John Kotlavale Defence University. Dr. Dhanushi Abhinayaka, Consultant Gastroenterologist, District General Hospital, Ambilipitia. Thank you all. We now begin the second symposium of the day on chronic pancreatitis. Let me invite the 2 distinguished panelists, Dr. Sanjeev Arya Singha, Consultant Gastroenterologist, National Hospital of Sri Lanka, and Dr. Nilesh Fernandopulle, Consultant Gastroenterologist and Senior Lecturer, Gastroenterology and Endoscopy Center, National Hospital of Sri Lanka. Over to you, sir.
Yes, so welcome to the second part of this specialty update, and we will be having this symposium on chronic pancreatitis. Let me invite to start off with the first lecture, Evaluation of Chronic Pancreatitis, Dr. Tharanga Liyanarachi. Dr. Tharanga is the consultant gastroenterologist at the District General Hospital of Gampa. Over to you, Taranga.
Thank you, sir. We would move on to the Symposium of Chronic Pancreatitis now. So I will first begin with evaluation of chronic pancreatitis. I will present you an actual case of a 33-year-old male admitted last month complaining of upper abdominal pain of 4 days duration. These were taken from the busy house of scissors clerking, which was radiated into back, which was worsened with meals. And he had a past medical history of chronic pancreatitis. He didn't have any allergies, and he used to be a heavy alcohol consumer. But he had a card of previous admission, which mentioned acute on chronic pancreatitis, where he has admitted with the same symptom and with being hemodynamically stable, treated with IV fluids and analgesics, and after the ultrasound scan abdomen, and he was discharged. So what is chronic pancreatitis? Earlier, it was defined as continuing inflammatory disease of the pancreas characterized by irreversible morphological change and typically causing pain and or permanent loss of function. But now there is a new definition where we define chronic pancreatitis as a fibroinflammatory syndrome of the pancreas in which repetitive episodes of pancreatic inflammation of various intensities and length lead to irreversible pancreatic tissue damage resulting in malabsorption, diabetes, pain, and increased risk of pancreatic cancer. And in chronic pancreatitis, quality of life and life expectancy also reduced. So what are the etiologies? Alcohol, idiopathic, when all the workup found to be negative, metabolic causes, abnormal anatomy, hereditary causes, including genetics, autoimmune, and smoking. There are two mnemonics that we can remember about the etiology factors. One is called Tiger O system. Toxic metabolic, idiopathic, genetic, autoimmune, recurrent acute or severe pancreatitis, and obstructive. But in most of our patients, the causes are multifactorial. If we move on to toxic metabolic causes, alcohol is a major factor in chronic pancreatitis. If a person is consuming more than 60 grams of alcohol a day, more than 1 year, he is at risk of getting pancreatitis. And also smoking. Unlike alcohol, if he ever smokes, like even less than 1 pack of cigarettes a day, puts the patient at risk of developing chronic pancreatitis. Also, hypercalcemia, hypertriglyceridemia are well-known factors. Idiopathic causes are idiopathic. The reason could be idiopathic when we can't find any reason for pancreatitis. Now, with emerging new investigations, the rate of idiopathic pancreatitis is becoming rare, but we can only consider them as idiopathic pancreatitis only after a full workup. So in the full workup, there should be detailed history, alcohol and tobacco use, whether the patient has other medical issues like hyperparathyroidism, chronic kidney disease, hypertriglyceridemia, or family history, and blood test, initial tests like full blood count, liver profile, and fasting blood sugar. Cross-sectional imaging, that's the initial investigations of cross-sectional imaging, CT or MRI, and endoscopic ultrasound. If CT or MRI is indeterminate, endoscopic ultrasound is sensitive in early disease, and the testing for exocrine function, fecal elastase levels, and breath tests. I will be speaking about them later. And genetic testing for younger patients less than 35 years or patients with family history should be tested for genetic causes. And autoimmune markers, IgG4 levels, and history of immunotherapy. Moving on to the third one, genetic causes. There are autosomal dominant as well as autosomal recessive genetic causes. The most common is PRSS1 gene mutation, and also SPINK1 and CFTR mutations in cystic fibrosis. So when you look for genetic testing, it involves wider family testing and reproductive considerations for the patients, and also to advise them about the surgical implications, and the cancer screening is a must in certain genetic conditions. We will be dealing more about this autoimmune pancreatitis later in the symposium, but there can be isolated autoimmune chronic pancreatitis or autoimmune chronic pancreatitis associated with IgG4 related diseases, or autoimmune pancreatitis associated with inflammatory bowel disease. Immunotherapy given for certain cancers can also give rise to autoimmune chronic pancreatitis. Recurrent and severe pancreatitis can cause chronic pancreatitis in post-necrotic acute pancreatitis, and recurrent acute pancreatitis due to vascular diseases, due to ischemia, and post-irradiation can be causes. So risk of progression from acute pancreatitis to recurrent acute pancreatitis is about 22%. But progression of recurrent acute pancreatitis to chronic pancreatitis is about 36%. So we have to be careful if a patient presents with recurrent acute pancreatitis. That is 2 episodes of pancreatitis within 3 months. And obstructive causes, ductal obstruction with tumor, stones or strictures, preampullary cysts in the pancreas, and post-traumatic pancreatic duct scars. Sphincter disorders are controversial in this text. There are certain things that we can consider as no risk factors for chronic pancreatitis, although they were initially investigated. Cholelithiasis, microlithiasis, or gallbladder sludge are not risk factors for chronic pancreatitis. Diabetes mellitus type 1 or 2 per se won't cause chronic pancreatitis, and anatomical variations like pancreatic divisum are not considered as causes for chronic pancreatitis. So how to establish diagnosis? So for the definitive diagnosis, there should be imaging findings, cross-sectional imaging, either MRI, CT, or EUS, secretin enhanced MRCP or ERCP, or histological proof, which would be the gold standard but very rarely done, or repetitive pain episodes with increase of pancreatic enzymes and pancreatic insufficiency and probable chronic pancreatitis on imaging. We can come to a diagnosis of probable chronic pancreatitis if there are repetitive pain episodes with increase of pancreatic enzymes or pancreatic insufficiency and probable chronic pancreatitis on imaging. So how do they normally present? Epigastric pain, radiating into back, recurrent acute pancreatitis episodes, weight loss, malnutrition, steatorrhea, diabetes mellitus, or it could be even incidental. So these are the findings of our patient. So initially, the previous admission, he has had very high AST ALT levels as well as serum amylase levels, as you can see, starting from 1640 serum amylase and then dropping to 510 over the during the hospital stay, and also high AST and ALT levels and high gamma GT levels, probably due to his alcohol consumption. And this admission, again, he has had high amylase levels of 870, but not much of AST and ALT rise, and relatively okay CRP levels. So I'm going to ask you a question now. You can raise your hands. So normal serum lipase or amylase levels excludes the diagnosis of chronic pancreatitis. Who says true? Who says false? Can you raise your hands? Okay, good. At least you all are not sleeping. So yes. So just because amylase levels or lipase levels are normal, you can't exclude the diagnosis of chronic pancreatitis because they tend to decrease in level over the course of the disease. So in laboratory findings, none are pathognomonic. So lipase and amylase are not diagnostic and often low. And there can be consequences of exocrine insufficiency. You have to check for vitamin A, D, E, K levels and decreased fecal elastase, and diabetes as a consequence of endocrine insufficiency. In laboratory findings, a decreased fecal elastase level less than 200 is pathognomonic of chronic pancreatitis. Who thinks it's true? Who thinks it's false? Yeah, no answer. Okay, I'll come to that later. So in our patients, we have gone ahead with the ultrasound scan imaging, which showed fatty liver and enlarged pancreas with calcific foci inside and intrapancreatic cyst of 3 by 1.4 centimeters. And they have mentioned that it could be due to acute and chronic pancreatitis, and they have suggested serum amylase and LFT. And they have repeated the scan, probably a CR scan, which showed a pancreatic pseudocyst of 2.4 centimeters into 2 centimeters and suggested contrast-enhanced CT of the abdomen. So in the diagnosis of chronic pancreatitis, there are two things to consider: test of structure and test of function. So test of structure, CT or MRI, are the first line in diagnosis. If CT or MRI do not give any diagnosis, then we can go for endoscopic ultrasound because it can pick up early stages of chronic pancreatitis. And then secretin enhanced MRCP when the diagnosis is uncertain and early. Histological examination is the gold standard, although not done often. So this is a picture of CECT abdomen showing calcification in the pancreas and a pseudocyst. This is a MRI abdomen showing gross dilatation of the pancreatic duct and gland atrophy. And there are calcifications in duct showing the calculi. And secretin enhanced MRCP, where secretin is given IV, and they've done the MRCP, which showed a calculi. And endoscopic ultrasound, there are certain criteria being developed these days to identify chronic pancreatitis early, which are namely Rossmann criteria. So in the test of function, it's important a means of diagnosing exocrine pancreatic insufficiency. However, it's not compulsory to have exocrine pancreatic insufficiency to diagnose chronic pancreatitis, because usually 90% of the pancreatic parenchyma should be lost for them to develop symptoms of exocrine pancreatic insufficiency like steatorrhea, aciduria, and vitamin deficiency. This is the same thing. So the gold standard test would be coefficient of fat absorption, where the patient is given 5 days, a diet containing 100 grams per day, every day, and last 3 days, the stools are collected and measured for the fat levels. And if the mean fecal fat per day is more than 7 grams of steatorrhea, then the patient is will be considered to have exocrine pancreatic insufficiency. And there are certain hormonal tests of pancreatic function, CCK stimulation test, where cholecystokinin is injected and pancreatic duodenal aspiration is done using a tube and collected and checked for the trypsin levels, which is cumbersome and not widely available, and it takes long time to do. And there is another test, secretin stimulation test, which is also given IV and using the endoscopy, collected and measured the bicarbonate levels, which is also not widely available and not used in the clinical practice. This is how they are done. And there's another test where you're given carbon labeled, 13C labeled triglycerides, and check the breath, the level of carbon dioxide which is exhaled. So if enough lipase is present, then they will have a good amount of carbon dioxide excretion in the breath test. But it takes a long duration, even though it is highly sensitive. And there is another test. We can do serum trypsinogen or trypsin levels which is only done in newborns suspected of cystic fibrosis. Fecal elastase 1, this is the test that we can do, which is universally available, easily obtainable, and non-invasive, but it has a moderate sensitivity and limited specificity in diarrhea and limited use in mild disease. So we should always remember to look for the nutritional evaluation of the patient, anthropometry, body weight, BMI, weight loss, mid-arm circumference, muscle mass, and grip strength, and plasma proteins like albumin, prealbumin, transferrin, fat-soluble vitamin levels, and check for other micronutrients like magnesium, selenium, and zinc. Sometimes we don't need to test for the pancreatic enzyme insufficiency when they have total pancreatectomy, pancreatic duodenectomy, or pancreatic head cancer. We'll have to definitely go for pancreatic enzyme replacement. So if our patient presented with worsening abdominal pain and progressive weight loss, what should be considered? Pancreatic exocrine insufficiency, diabetes mellitus, pancreatic cancer, duodenal stenosis, or all of the above. I think it's all of the above. And what examination would you not consider relevant to monitor for the nutritional complications of in this chronic pancreatitis patient? Hand grip strength, DEXA scan, thyroid function test, vitamin levels, and BMI. I think the answer is thyroid function levels. So I'd like to finish my talk with this slide. This is like a nice summary slide. So chronic pancreatitis incidence is rising, and it is associated with substantial morbidity and mortality. And 24 patients with acute pancreatitis progress to chronic pancreatitis. Smoking is the strongest dependent risk factors, and pain intensity and elevation of pancreatic enzymes change over the course of the disease, as well as the exocrine pancreatic function decrease gradually along the course of the line. These are my references, and I would be happy to answer any questions at the end of the symposium. Thank you.
Taranga, for nicely going through the evaluation of chronic pancreatitis. Now over to Shamila to take us through about management of chronic pancreatitis. Shamila is the consultant gastroenterologist at Colombo Teaching Hospital, and he'll be talking to us on management of chronic pancreatitis.
Thank you, Nilesh, for your kind introduction, and thank you, CCP and the organizing committee, giving this opportunity to me to talk about the management of chronic pancreatitis. As Taranga evaluated, so I'm not going to detail on this side. It's a chronic, progressive, irreversible fibrotic disease. And directly come into the management. So first and foremost is we have to deal with all the patients. We have to take a little bit more time to quantify their smoking and alcohol history. And always we have to advise them, strongly advise them to stop alcohol and smoking. If things not fail, then you have to refer somebody for a program where this very dedicated cessation program is available, because alcohol and smoking is cause progression of the disease, as well as it will increase the risk of pancreatic cancer. Even most of the guidelines, international guidelines, says somebody who's continues to drink alcohol or continues to smoke, so they are not allowed them to go into any interventions, especially endoscopic or surgical interventions for the pain management, because the people who they do take themselves harm, so they don't do any interventions unless it's in an emergency. So we have to monitor and treat exocrine insufficiency and diabetes. I will come into the later. And we have to maintain the nutritional intake and monitor for macronutritional and micronutritional deficiencies, and monitor bone health. So most of the chronic pancreatitis, up to 30% of them have osteopenia, and they do have less muscle mass as well, so they have high chance of low fragility fractures. So you have to assess them for bone health and treat accordingly. And 10 to 15% of them have osteoporosis as well. And little bit of dietary consideration. So, but we have to, so that little bit high carbs diet and low fat. Small frequent meals would be much help if they go into the more dietary, if you're going to do some dietary alterations. And pain management is very important. I will come that part into later. And you have to do regular screening of pancreatic cancers because this chronic pancreatitis has 8-fold high risk for pancreatic cancers. So you have to do regular monitoring, usually CT contrast and CT scan every 2 years. In selected cases, you can go more details or more evaluations to detect autoimmune disease, which is very treatable. And as Tanaka says, if you can found any cause of recurrent acute pancreatitis, which is treatable, so you have to look for any cause for any strictures or mass in the pancreatic head or recurrent gallstones pancreatitis, so it's very treatable and you can prevent chronic pancreatitis. So you have to look into that. And in selected patients, you can go ahead with the endoscopic or surgical treatments, or finally, you can go for a total pancreatectomy with islet cell autotransplantation. The pain management is more important because most of the patients of chronic pancreatitis, pain is the common symptoms, and it is very debilitating and associated with several physical and mental as well as social health outcomes. Mainly the pain because of the inflammatory mediators which released and which increase the interstitial pressure of the pancreas, leading to constant gland inflammations, and which can cause constant or intermittent pain, which can be exacerbated by meal. If somebody comes with the pain, you have to always think about whether it's simply pancreatitis itself, or we have to exclude any other cause like peptic ulcer disease, common in chronic pancreatitis, whether it's a complication of pancreatitis like pseudocyst or anything else, or a cancer. So again, to manage pain, so again you have to get an idea whether patients still continue to take alcohol or smoking. If it is the case, so you have to refer them for a cessation program. And pain management, as we all do, you can go to step ladder management plan, like you can start non-opioids as first line, but you can go ahead with the opioids for worsening and persistent pain, but you should be very cautious when prescribing opioids because some patients can go into dependent on opioids treatment. There are some adjunctive medications like tricyclic antidepressant, SSRI or gabapentin can be used, which can reduce the dose of opioids, and it also help in managing neuropathic pain which is associated with the chronic pancreatitis. Antioxidants like selenium or vitamin B, theanine, there are so many antioxidants. There are some trials says there are some benefits, and some says there is no much benefits compared to the placebo, but you can try in some selected cases if it is work for your patients. And pancreatic exocrine replacement treatment, pancreatic enzyme replacement treatments is again useful in the management of pain, but still some studies says that there is no place for pain management, but sometimes in my practice, I don't know, my practice I have seen if you replace with the pancreatic enzyme replacement therapy, patients' pain episodes are going to be less. The medical management of pain, so you can go up to the celiac plexus blockade that has varying efficacy, but it's basically it's transient. It's last less than 6 months. It's a procedure which involves injections of local anesthetic agents with or without steroids into the celiac ganglia, which can be done under endoscopic ultrasound guidance or as percutaneous or direct during surgery. And there are studies which have shown that endoscopic ultrasound guided injection to the ganglia has more effective compared to the other options. And I would say again that this ganglion box is not permanent, so you have to go again and again. when it comes to the endoscopic treatment to reduce pain attacks, why you get the pain? Because patients who have the chronic pancreatitis with main pancreatic duct stricture or stone, because of the block of the flow and inflammations and increased pressure, which can cause pain. So you can decompress of the pancreatic duct by endoscopic procedures. You can do stenting to the stricture, or you can remove stones, or you can, if larger stones or radiopaque stones, which more than 5 millimeters, you can go into the extracorporeal shockwave lithotripsy or direct laser lithotripsy or hydraulic lithotripsy. So you can reduce, you can fragment the stones and take it out. And you can decompress the pancreatic duct endoscopically. If you decompress, that can result in pain reduction, as well as if you do decompression, so it will reduce the progression of the disease and it will preserve the pancreatic exocrine and endocrine function. There are so many surgeries which has done for management of pain, where it's very in selected patients, which is reserved for severe disease, which long-standing symptoms in the presence of pancreatic duct dilatation due to stricture of stone. Surgery be performed safely and with minimal perioperative morbidity and mortality. The several options have been developed whereby varying amounts of the pancreas are removed to ensure improved drainage of pancreatic fluid. Most modern procedures are parenchymal sparing approaches, but still pancreatectomy concomitantly with an islet cell transplant become a newer fashion. And there are so many surgical procedures, Whipple's, Frey and Beger, Burner, Festo, which are the procedures they do. They take the most of the pancreatic tissues out, especially in the head or distal part of the pancreas, preserving the some pancreatic tissues. Replacing the pancreatic enzymes, where the pancreatic exocrine insufficiency, the patients will come with the malabsorption and evidence of nutritional deficiency, which diagnosed by pancreatic function test in an appropriate clinical context. And if it is the case, you should always treat with pancreatic exocrine replacement, enzyme replacement treatment, and dietary advice and dietary support. Pancreatic enzyme replacement treatment enhance fat and protein absorption, and it will improve weight, nutritional status, and symptoms, as well as the quality of life. And it will reduce the complications and mortality. The pancreatic enzymes you have to take with each meal, and the recommended dose is 40 to 50,000 units with main meals, and for 20 to 25,000 units with snacks. And you can adjust the dose depending on the severity of pancreatic exocrine insufficiency, age, and the fat content in your patient's meal. And sometimes if you can add proton pump inhibitor concomitantly. That will reduce the damage of the enzymes at more acidic level, which will improve the that will increase the enzymes level in the small bowel, which will increase absorption. Little bit of autoimmune pancreatitis, which is very treatable conditions if you can identify early. Is a clinical presentation with obstructive jaundice, with or without pancreatic mass, and histologically by lymphocytic infiltrate and some fibrosis in histology, and therapeutically therapeutically by dramatic response to steroids. So there are imagine this. There's a cut tail sign, sausage-like narrowing of main pancreas without upstream dilatation and no calcifications. If you do MRCP, your duct system is very narrowed, and sometimes there will be strictures, but you can't see any calcification. So that is one sign, and sausage-shaped swollen pancreas. And serum IgG4 level will be high, and it can be more than 4 times of the upper limit of normal. And there will be other organ involvement, maybe biliary tract, salivary gland, retroperitoneal lobe. They can be associated with the inflammatory bowel disease as well. The histology mentions that you can have lymphocytic predominant and fibrotic histology, and it will respond to steroid treatment. And you can assess the response by doing imaging and doing CA19- in 2 weeks' time. Management of complications. So the chronic pancreatitis can go into some complications like developing pseudocyst. Not like in acute pancreatitis, the pseudocyst, which is symptomatic. So then you have to treat then and there. But in acute pancreatitis, you can wait, but here you can't wait. So you have a lot of procedures you can be done by percutaneous drainage, intrasphincteric drainage, or intratransmural drainage by EUS. The transmural drainage by endoscopic ultrasound is the best way of treating pseudocyst in chronic pancreatitis. Biliary strictures, because of the chronic pancreatitis, head regions, you can get the biliary strictures in the lower CBD. It's a benign stricture, so you can manage by putting stenting or dilatation. And you can get the pseudoaneurysm around the head of the pancreatic regions, which can manage it from some sort of coiling or putting some thrombus generations. And you have to monitor or surveillance cancer, and you have to deal malignant or pancreatic cancer accordingly. Those are my references, and I'm happy to take any questions, and thanks for the kind attention. So take home, chronic pancreatitis remains a challenging condition, and there are some effective, or I would say partially effective treatment available to reduce symptoms and complications, and no cure. And multiple approaches and MDT collaborations will improve the outcome. Thank you very much.
Right, the last speaker for the day is Dr. Eranda Lakshman, and he will be going through an uncommon case of chronic pancreatitis. Eranda is the consultant gastroenterologist at the District General Hospital, Matale.
Good afternoon, everybody. Thank you very much for the CCP and the Sri Lanka Gastroenterology Society to give me this opportunity. Today, I'm going to talk to you about a case of uncommon cause of pancreatitis. This is one of the classic case summary of such kind of a disease, and I got a patient who is a gentleman whose age is 65 years old, and his main concern was that his yellowish discoloration of eyes for a last 3 months duration with a weight loss, but he did not came up with any other concerns or other symptoms, and his past medical history was only significant for diabetes. In a patient who coming with a yellowish discoloration of eyes for a few months duration, that we usually inquire in history about more causes for a liver or non-liver causes for jaundice. So I had to go through the history, but he denied all the cause of hepatotoxic drugs, alternative medications, alcohol use, or any hematological malignancies, or blood transfusion histories, sexual promiscuity, or any other form of hematological malignancies or blood transfusions. And he denied any significant family or surgical history as well. And on examination, he was quite well and stable vitals, and the temperature was normal, On abdominal examination, the only finding was the tenderness over the abdomen and the epigastric region. Apart from the icterus, all the other examinations revealed normal. So I cross after, in my mind, it crossed a gentleman who is in 60s in his age, coming with a long-standing history of painless jaundice with a weight loss. So I thought, what could be the reasons? So I think any of us in this hall has come across this scenario. So first thing we think about whether this is cancer or not cancer. If it is a cancer, where does this coming from? Is the hepatobiliary region? Is it from the pancreas? Or is this non-cancer, which is coming from liver, biliary system, or pancreas, or any other else? So what are we going to do next? As he has jaundice, I'm going to look on his liver biochemistry as the first thing. These are the differential diagnoses I considered, and this is the liver biochemistry. As you can see, the liver biochemistry is deranged, and when we interpret it, it shows cholestatic pattern derangement. So have we excluded or ruled in any specific diagnosis from the history, examination, and from this liver test? The answer is no. Still, the differential diagnoses are opened. So I need to go into further investigations to rule in or rule out my differential diagnosis. And as anybody coming with the cholestatic pattern, the next step I would consider is the imaging, and the most widely available and easy accessible first line imaging would be the scan. The ultrasound scan, it did not show any hepatobiliary dilatation, intrahepatic dilatation, or any solid masses or lymph nodes, but it only showed the hypoechoic enlarged pancreas. So have we come to any conclusion after ultrasound scan? So I left behind so many doubts, so I need to clarify it and come to a diagnosis. So I wanted more information from further advanced imaging. So the next available thing was the CT contrast study. So I did the contrast study with the pancreatic protocol, and it commented as there's a pancreas which is sausage shaped and capsule-like rim, and it did not show convincing evidence of pancreatic malignancy or any other form of obstruction, or abdomen did not show any other abnormalities, and there was no pancreatic dilatation as well. And but I thought I should move forward a little bit and take more details to confirm my diagnosis and differentials. So I did the MRI study with MRCP, and it showed distal part of the common bile duct stricture without dilatation, and the overall imaging appearances are suggestive of benign nature rather malignance. And there were no focal obstructing lesion as well. And interestingly, the pancreatic duct, it did not show dilatation, rather it shows segmental narrowing. So these are the studies, and you can see the arrow, white arrow, which is a halo sign, the rim-like structure, and the sausage-like appearance is the pancreas. And then, so the patient, gentleman who is in his 60s, coming with a painless jaundice and cholestatic picture in the liver biochemistry, and the scan and imaging study shows the sausage-like pancreas with the halo sign. And then I think the pancreatic cancer, biliary cancer, cholangiocancer are the going down of the bottom of the list of the differentials. So I thought I should think more about the autoimmune pancreatitis. So I wanted to confirm and reinforce and support my diagnosis. So I went to do the immunological workup So I did the IgG level, and it came as nearly 300, which was more than the second upper time of the normal, more than 2 times of the upper times of the normal. But all other autoimmune markers were negative, as well as the cancer markers of the pancreatobiliary system. So I thought this is autoimmune pancreatitis type 1 based on these criteria. It is imaging, histopresentation, and the elevated IgG4 levels, absence of malignancy, and I gave a course of steroid, which is 0.6 milligram per kg per day, nearly 40 grams per day for 2 weeks, and repeated the CT. It shows resolutions of all the biochemical abnormalities and the imaging abnormalities and overall well-being of the patients. So it confirmed the diagnosis of autoimmune pancreatitis type 1, and we needed to follow up for at least 1 month, or steroid we have to give for nearly about 3 months. There is a recurrence of chance of autoimmune pancreatitis type 1. That is, autoimmune pancreatitis is one of the rare causes of chronic pancreatitis. In this type, its most striking feature is they don't present commonly with the pain, and only the minor fraction, nearly less than 30%. The common presentation is around 80 to 90 with the painless jaundice, and those are mostly the Asian population people rather the European people, and this disease was identified in 1995 by the Japanese team. And this classic autoimmune type 1, as I shown in that case history, they responded very well, and they do get in their 60s in age. And also, the disease diagnosis is supportive. This doesn't occur per se by autoimmune pancreas alone. It also has other organ involvement, commonly with the eyes and the parotid glands and the retroperitoneal fibrosis and the kidneys as well. And this will be confirmed, and we can see on the imaging as well. And that is, there are another type of autoimmune pancreatitis, which we call as type 2 autoimmune pancreatitis. That is very, very difficult to diagnose because they usually present with the same clinical scenario, and they do have the acute presentation with common acute pancreatitis presentation. But in imaging, they usually show the focal pancreatic mass with the halo signs. That's where we trapped in the diagnosis to diagnose whether cancer or autoimmune disease. So what we have, can we only confidently rule out or rule in autoimmune pancreatitis? In this case, the answer in the literature is it's very, very difficult, and we need more evidence, which is the tissue diagnosis. The tissue diagnosis, usually we have to go with the endoscopic ultrasound guided fine needle aspiration, and which will show the classic histological appearance of IgG4 related plasma cell infiltration, which is in histology they will report it as sororiform fibrosis. This is the histology of the classic IgG4 related autoimmune disease. And the learning point is AIP is a very uncommon one and very difficult to diagnose. And there are 2 main types, and type 1 is more common in Asian countries, and it's can be diagnosed without histology, but in type 2 it's very difficult, and we need more tissue diagnosis. And type 1 is a part of IgG4 related systemic disease, rather it himself alone. And this brings to end of my talk. And again, I am thanking for the college and the CCP. And I would also like to remind that gastroenterology sessions will be this time happen in Kandy, Grand Canyon Hotel. And there are interesting endoscopic workshops and good lectures. And we would like to invite all to be there with us on gastroenterology sessions. Thank you.
Thank you, Ananda. I know all of you all are very hungry and waiting to go out. Any questions, burning questions that you all want to clarify from the experts in the panel? There are a lot of gastroenterologists in the audience also. Prof. Niriel has a question for sure.
No one from the audience?
No. I think you can start, go on, yeah.
Yeah. So Tarang, I was surprised that you put pancreatic enzymes in the diagnostic workup of chronic pancreatitis. Do we really do pancreatic enzymes to diagnose chronic pancreatitis? It's on.
So it is not necessary, but it is something we have to do.
That's it.
Yeah.
It's not necessary.
It's not necessary.
Because in acute pancreatitis diagnostic criteria, we have three.
Yes.
Suggestive pain, 3 times more than upper limit of normal, elevation of enzymes, and suggestive scan. So if you have
either 2
of 3, you can diagnose. That is acute pancreatitis.
Yes, sir.
Chronic pancreatitis, there is no, we don't talk about the pancreatic enzymes actually.
Yes.
So what we talk about is suggestive pain, then we talk about the imaging, and we talk about the loss of function, either exocrine or endocrine. So I think that is probably not relevant. But the one point that you mentioned is that in acute pancreatitis, the enzymes are not diagnostic. That is why it is only one criteria out of 3. Especially amylase can be normal. So if the amylase is normal, you have to do a lipase. Lipase is much more sensitive in that case. Just one comment for Chamila, if there is time. What you mentioned about antioxidants and PERT in the management of pain, which group of patients do you think this is helpful?
Yeah, basically the people who not consume alcohol. The patients who consume alcohol, antioxidant does not work. The other groups, you can try antioxidant.
I think in the trials, if you just separate the people who responded from not responded, then those who responded to antioxidants and the PERT was the people who had early disease. So in late disease, it does not work actually when they have diabetes, when they have exocrine insufficiency, when they have pain along with those complications, it doesn't work actually. So it is for only the early stage. Thank you.
Any other questions from Shamli? Just one thing, if you just highlight, because about this nutrition part is a big problem with chronic pancreatitis. Do you want to just highlight quick about the nutritional, just few advices that you give to chronic pancreatitis patients about this fat restriction, whether you should restrict, whether you should not restrict, what the diet would be generally? Quick few words.
Generally, it should be the more frequent small meals would be advised rather than having a big meals. And average oil contents are now advocated. They don't ask to restrict fat and proteins when you are taking enzyme replacement. But carbohydrate won't be any issue. But it should be again the balanced diet. And the nutritional, the other side is there are so many vitamins, especially fat soluble vitamin K will be maybe lower in the patients who have chronic pancreatitis. So you have to assess. But somebody who's taking enough meals and tolerating the gain weight, and if you treat with enough enzymes, then again you don't need to replace vitamin, because it will be correct with your normal diet. But if there are any evidence which shows that patients, or if you examine, there will be some changes in the skin, or if you do any biochemical assessment, so if they are very, very low, then there's a place for replacement. But in the subtle case, just replacing with the enzyme replacement might it itself enough. No need to replace all the micronutrients and vitamins.
Nilesh, just one more comment. I think, Chamila, you nicely mentioned that in chronic pancreatitis management, we tend to, concentrate on the alcohol abstinence. But I think smoking is as important as alcohol. I think we should be telling our patients.
Even
both.
stopping one pack of cigarettes will reduce the cancer incidence. Yeah. They have shown that the people who continue to smoke has a higher risk of disease progression as well as the occurrence of cancers. So it's very important. Just
Chamila, what is the place for ESWL? Would you like to comment on? Basically, I know that there is a place for when there is calcific pancreatitis. Is there any place in pain management?
Yes. Most of the times, most of these interventions we do to manage the pain. Because the pain is the most common symptoms and is very debilitating. The patients who have stones with ductal dilatation, so you have to do some interventions who are coming with a recurrent attack of pain and hospitalization. So the dealing with the stones, if the stones is less than 5 millimeter, radio opaque stones, so you can take it out without doing anything, or you can just put a stent through with the stones. That itself is enough. But the stones is radiolucents or stones. The size is more than 5 millimeters, so you have to do something because it's very difficult to take it out by your basket or balloon, or you can't put the stent. So then you can have three different steps. One is that you can use hydraulic laserlithotripsy if you are available, or you can do laser pancreatoscopy and laserlithotripsy, or ESWL. The laserlithotripsy or hydraulic lithotripsy has better place because you see direct visualization but extracorporeal shockwave lithotripsy as good as well as, but sometimes you need 2 or 3 sessions because you have to fragment is less than, the fragmentation should be less than 3 millimeter for all stones, and if you couple with endoscopy clearance and stenting has better chance. But the issue is that some guidelines, they deal with the cost effectiveness. So if you couple with the endoscopy clearance and ESW, the cost is very high. So sometimes they do only ESWL more sessions rather than going. In my practice, what I do is that once the patients come back with the ESWL, then I go and I put an stent and I try to clear with salines and put a stent. Otherwise, I have seen even after the fragmentations, they fuse together later. So I try to take them early and do a stent, or try to do some saline irrigations to remove all the stones out.
Okay, any more questions? Just I want to highlight about the nutrition part. So there is no fat restriction, or you should not restrict fat in chronic pancreatitis patients, although it's commonly done. So that's something that you all should not do. Yeah, I think all the speakers have stick to time, and we have managed to finish our session by 1:30. CCP wants us to hand over some certificates of appreciation to the speakers. Can I get my other co-chair to do that? First of all, Dr. Taranga Lianarachi. Dr. Chamila Ranavaka. And Dr. Eranda Lakshman.
Thank you all. And also I would like to invite Dr. Sandeepana Gamage to present the certificates of appreciation to our chairpersons. Dr. Sanjeev R. Singha, Consultant Gastroenterologist, National Hospital of Sri Lanka. Dr. Nilesh Vanandapulle, Consultant Gastroenterologist and Senior Lecturer, Gastroenterology and Endoscopy Center, National Hospital of Sri Lanka. Thank you all. That brings us to the end of today's specialty update on gastroenterology. On behalf of the Ceylon College of Physicians, we extend our gratitude to the Sri Lanka Society of Gastroenterology. And also, our sincere thanks to all the speakers, moderators, and participants for contributing this highly educational program. Please remember that ECPD certificates will be provided to all the participants. Thank you for joining us and have a pleasant day.